So to add to the usual disclaimers, I should add that this field of pharmacogenetics is something that I'm new to. I think I've been using the testing regularly for just over a year now. I've probably tested, Dan, you can correct me, but it's 110 patients, something like that at last count. So I just picked out a few sort of illustrative cases to give you an idea of just how helpful this knowledge can be. So JJ is a 43-year-old guy who had Hodgkin's disease in his 20s, super fit, eats right, exercises well, even did a triathlon a couple years ago. But in routine long-term follow-up of these childhood cancer survivors, was found to have atherosclerosis in his aorta and his carotids at a fairly young age. So his cardiologist recommended that he be put on a statin for this, but he had a history of multiple medication intolerances, including being very sensitive to small doses of medications. So in particular, his cardiologist said, well, okay, let's pick fluvastatin, because that's one of the statins that generally has fewer side effects than more commonly used statins than like simvastatin and atorvastatin, Zocor and Lipitor. But because of his history of adverse reactions and the potential many adverse reactions of statins, I said, well, why don't we do his pharmacogenetic testing first, so that we're not just giving him something and keeping our fingers crossed and hoping that he doesn't have a problem with it. So ironically enough, his testing showed that he didn't have problems with 3A4, which is the major pathway for drugs like Lipitor and Zocor, but he was an intermediate metabolizer of 2C9. TC9 happens to be an important enzyme for the breakdown of fluvastatin. And the use-strict software here gives you an estimate of about 50% increase in drug levels in intermediate metabolizers. So he might have been okay with this, but this raises an issue that I wanted to just come back to, that certainly in terms of mast cell disease and typically we think of people having adverse reactions to medications, we give them the medication, and if they're going to have a reaction to it, they're going to have a reaction to it. In the case of particularly intermediate or slightly slow metabolizers, if they're accumulating drug little by little, if they take a dose every day and for some reason that medication stays in their body for 26 or 28 hours instead of 24, they may not have side effects for several months. And when they come in several months later, not feeling well, neither you nor the patient is going to think it's related to their medication because they've been on the medication for months without problems. So it's something that you need to think about. So we know now that that being an intermediate metabolizer, he makes less than the usual amount of 2C9. So drugs that go through 2C9 will be metabolized more slowly and have an increased risk of accumulating and causing side effects. And ironically, the drug we were considering, because it usually has a lower risk of side effects, in this patient would have had a higher risk of side effects. CH is a young woman with Ehlers-Danlos, with chronic joint pain from joint laxity, who surprisingly enough, Pradeep mentioned this, we don't use a lot of NSAIDs in the hypermobile population, I think primarily because a lot of their pain is what I call mechanical pain as opposed to inflammatory pain. But in her case, she found NSAIDs were very helpful in relieving her pain. The problem was if she took them for more than about 3 or 4 days, she got terrible stomach pain. So her previous doctors had basically said, well, you can't take NSAIDs, too bad, you'll have to find something else for your pain. And even celecoxib, which is generally considered to be easier on your stomach than other NSAIDs, she had a problem with after about 5 days. So I suggested pharmacogenetic testing, partly in the hopes that we would see that she was a poor 2C9 metabolizer, because I happen to know that naproxen is not metabolized primarily by 2C9, and I was hoping this might be an option for her, even though her previous doctors had said, oh, no, you can't take NSAIDs, don't try it. And so in fact, it turned out that she was not just an intermediate metabolizer, she was a poor 2C9 metabolizer. So making little or no 2C9, any drug that she took that was primarily dependent on 2C9 for metabolism was going to build up pretty rapidly in her system. and it pretty much explained why after 4 or 5 days she was having toxicity. So, and again, the software here shows us that celecoxib can have huge increases in serum levels in people who are poor metabolizers. So they actually have a little box you can click on called alternates, and if you click on the alternate, in this case, the software would show you that naproxen is much less dependent on 2C9 for its metabolism, and in fact, she's now taking naproxen. It's been very effective for her pain. I've encouraged her to take it once a day instead of twice a day to minimize any chance that it's going to cause a problem. But so far, she's had none of the GI problems she had with her NSAIDs, and she's having significant pain relief. KM, let me think about it. Okay, trying to remember who KM is. KM is another Ehlers-Danlos patient with a long history of both depression and chronic pain. Several years before I saw her, she'd been treated with venlafaxine or Effexor, which at the time was a good option, effective both for depression and for pain. Cymbalta wasn't available at that time, Savella wasn't available yet. And it seemed to help her feel better initially. But then after a couple months, she started dragging again, not sleeping as well, just in general not feeling as well. So our physicians felt, okay, you know, your depression's getting worse, you're stressed, there's too many other things going on, it's time to increase your dose. So her dose was increased. Again, a couple months later, her symptoms seemed to get worse, she seemed to be not feeling well again, so her dose was increased again. And I forget if it was after the third or fourth dose increase, she became manic. And unfortunately, her physicians didn't really recognize she was manic at the time. She made some bad life decisions. You know, the symptoms of mania are things like spending too much money, and she got in trouble. And it's taken her a long time to undo those problems. And the other thing she said was that even though she's very skinny, she, you know, weighs 100 pounds, maybe 105 on a good day, that when somebody gave her Percocet, she needed to take 2 Percocets. She needed at least 10 milligrams of oxycodone to get pain relief. So unfortunately, her previous physician had mistaken the signs of venlafaxine accumulating in her system for the need for an increase in dose. And her previous physician also said, well, gee, 10 milligrams of oxycodone, that's too much pain medicine for somebody your size and your age. You shouldn't need that much. So we did her pharmacogenetic testing and found that, in fact, she was a poor metabolizer of 2D6. So again, making little or no 2D6, venlafaxine is primarily dependent on 2D6 for its metabolism. So venlafaxine we'd expect to be accumulating over time. And so what was happening is every couple of months the drug would accumulate, she would have symptoms of toxicity, and rather than recognizing that these were drug accumulation side effects, they were mistaken for worsening of the underlying condition, and her dose, instead of being reduced, was increased. So oxycodone, as Brian mentioned, is a little wrinkle on the general theme here, in that we worry most in slow 2D6 metabolizers that drugs are going to not be broken down well and they'll accumulate. In the cases of, as Brian mentioned, codeine and oxycodone and hydrocodone, they're actually broken down or metabolized into more active forms, more potent narcotics by 2D6. So patients who are poor 2D6 metabolizers won't convert oxycodone and hydrocodone into oxymorphone and oxycodone. And I don't know the relative potencies. I think oxymorphone is like 20 to 30 times more potent than hydrocodone. And then hydrocodone, I think. So there's a huge difference. If you don't metabolize one for the other, hydrocodone has a little narcotic potency, but not much on its, but not much compared to its metabolite. So clearly, our pharmacogenetic testing explained both of these problems that this patient had been having with medication. And here's what the UScript software shows, that in her case, Effexor, the parent drug, accumulating significantly in a poor metabolizer, and the problem with oxycodone being oxymorphone, the much more active metabolite, being significantly reduced in poor metabolizer. So you don't have to figure this all out for yourself. It's in the software. Case 4 is a woman with a long history of fibromyalgia, also hypermobile, chronic pain, depression, poor sleep, the usual vicious cycle of fibromyalgia, despite being on a lot of pain medication, a lot of antidepressants, long list of medications. And I'll have to say that in this case, first thing I did was suggest that she increase her Cymbalta dose, since she was on a pretty small dose. And I thought, well, bigger dose might help your pain, your mood, your fatigue. In fact, a bigger dose just made her feel worse. So then I thought, well, okay, I suggested she increase her Wellbutrin dose, thinking that might also help with fatigue and mood, but that also made her feel worse. So then I got smart and I said, okay, something's not right here. Let's look at your pharmacogenetics. So, and this is the full report you'll typically see, and you see again, this woman was a 2D6 poor metabolizer. So that had many implications for her treatment. First of all, we talked about oxycodone not being metabolized to oxymorphone. She was actually taking oxycodone several times a day. So she conceivably was even having issues with taking too much. And then Wellbutrin and Cymbalta, as I hadn't heard the expression phenoconversion, but taking 2D6 inhibitors only made a bad situation worse. And you'll see here, I think this is Wellbutrin being a strong 2D6 inhibitor and Cymbalta being a moderate 2D6 inhibitor. So, again, this is make things even more complicated. Wellbutrin itself is usually metabolized by 2E1, so it's not really a problem pharmacogenetically. But it has an active metabolite that's broken down by 2D6. So not only is she further inhibiting 2D6, but the active metabolite of Wellbutrin was not being broken down and was accumulating. And the software predicts that because active metabolite exposure increases, you should monitor the patient for things like tremor, agitation, dry mouth, and insomnia. Sure enough, she had all of these things, which had been attributed to other causes. So finally, and here I'm speculating, and I might be wrong, Cymbalta is partially metabolized by 2D6, so it's conceivable in a poor metabolizer that Cymbalta was actually accumulating in her system over time, and adding a 2D6 inhibitor, Wellbutrin, just aggravated that drug accumulation problem and made her feel worse. So right now we're in the process of reducing her doses and tapering her off a lot of the medications she's been on. So Dan made this slide for me. So personalized prescribing is a piece of the puzzle. Sometimes it's the answer, but sometimes it's not. So there are limitations to pharmacogenetic testing. So among these are patient's history might strongly suggest that they have a drug metabolism problem, but their pharmacogenetic testing comes back entirely normal. So among the possible explanations here are we don't have an assay yet for 3A4 rapid metabolizers. A lot of drugs are metabolized by 3A4, and unfortunately the testing will indicate whether they're either intermediate or normal. But some people who come back normal are actually fast, and those are the people clinically are going to tell you that, gee, narcotics work great, but they don't last very long. I take Percocet and I get 2 or 3 hours of pain relief. I take this, OxyContin that's supposed to last for 12 hours and it lasts 5. They will tell you that they're metabolizing medications quickly, but we don't have an assay for that. The marker just hasn't been found yet. Some drugs are metabolized through 1A2. We don't routinely test for 1A2. 1A2 metabolism is very complex, and so I think when we use the other ones account for, 75, 80, 90%. So there aren't that many drugs, but some drugs are metabolized by 1A2. The one that comes to mind, besides naproxen, which is largely 1A2, most often in this patient population probably is Flexeril, which is used a lot in chronic pain and fibromyalgia and things like that. And in fact, that's a pretty good diagnostic test for 1A2 metabolism. If somebody takes Flexeril and says, I took Flexeril once and I was a zombie for a day and a half, there's no point in then giving them tizanidine as another muscle relaxant drug because it's metabolized through the same pathway. And in fact, one of the things I do as a screen for 1A2 metabolizers is I ask people how they respond to caffeine, because caffeine is largely metabolized by 1A2. So if a patient says, oh no, if I have caffeine anytime after noon, I'm awake all night, then they're probably a slow metabolizer of 1A2, and you don't want to give them a drug that's metabolized that way. Similarly, if somebody says, I can have caffeine at an hour before bedtime, it doesn't keep me awake at all, they may be a fast metabolizer, and so again, you'd rather not choose a drug that's metabolized by 1A2 because it's probably not going to work very well. Another limitation, and this is where, we just have to realize that everybody's different and we don't have all the pieces of the puzzle yet. Sometimes results will suggest that a patient's going to have a problem with a particular medication, and yet they're taking that medication, they've been taking it for years, and they're not having a problem with it. Many drugs are metabolized by multiple pathways, some of which we know, some of which we don't know. So it's very possible that somebody who's taking a drug that's metabolized by 2D6, but they're a 2D6 poor metabolizer, there may be some other pathway that's picking up the slack that we haven't identified yet. In the case of 3A4 and 3A5, we know that there are some drugs that are normally metabolized by 3A4, but in the case of a patient who's a slow 3A4 or intermediate 3A4 metabolizer, 3A5 can pick up the slack. There's some drugs where that's been studied and been shown to be the case. There's some drugs that's been studied, shown not to be the case. Atorvastatin or Lipitor is in the second group. 3A5 does not pick up the slack in people who are slow metabolizers, but this also seems to vary from patient to patient as well. So there's still a lot of unknowns here. Then in some cases, pharmacogenetics suggests that a patient should not have a problem with a particular medication, but they do. And as Dr. Chopra mentioned earlier, many times the case is that they're reacting to something else in their tablet and not to the medication itself. And then we always have the possibility some patients just don't follow the rules. Their genes are different. They've got some other something in there that we haven't learned to measure yet. And then there are some cases where pharmacogenetics might suggest the drug would be ineffective, say in a fast metabolizer, but the drug seems to be working fine anyway. So this one I happened to look up because I was curious, and I found that even though Lexapro escitalopram is metabolized by 2C9, so you might think that a rapid metabolizer it would be less effective. It turns out that in rapid metabolizers, serum levels are only about 15% lower than they are in normal metabolizers. So it's not that significant effect. Proton pump inhibitors are also metabolized by 2C19, and yet clinically they seem to work fine in patients who are rapid 2C19 metabolizers. My speculation is that what's important for the efficacy of proton pump inhibitors is not how long they stay in the bloodstream, which is what we're measuring here, but how long they stay bound to the acid pump in the stomach. So maybe that they're binding to the acid pump and they're staying bound to the acid pump for a long time. Even though the drug is getting cleared more rapidly out of the bloodstream, the efficacy of the drug is not affected. Lastly, there are some situations where, and these I've been trying to give feedback to as I come across them, where the medical literature says there's a significant medication effect, but I just don't see that. So you'll see Wellbutrin listed as a strong 2D6 inhibitor, and yet I have a lot of patients on Wellbutrin. They're also taking drugs that are metabolized by 2D6. I don't see any clinical impact. Where I do see it, again, is in the case of so-called, what Brian called phenoconversion. I think if you were to add Wellbutrin to somebody who's already an intermediate or poor 2D6 metabolizer, that may be where this is a significant problem. But in a lot of patients, I don't see this as being a significant problem. On the other hand, there are cases where the literature suggests a minor effect, where I see this as often a very significant effect. So the most common one I see is steroids, which are considered to be a weak inducer of the 3A4 pathway, meaning they increase the metabolism of drugs through that pathway. They're considered minor, but I often see this as a very significant effect. Fraser and I have a patient like this who takes a strong steroid once a week, and it took her a long time to figure out why, when she took her weekly steroid, her pain would get worse and not better. And the answer was because the steroid was accelerating the metabolism of her fentanyl, of her narcotic. So in summary, hopefully if Brian and I together have convinced you that testing can be invaluable in explaining past adverse drug reactions and maximizing the likelihood of success and minimizing the risk of adverse reactions in choosing medications in the future, with the caveat that not all patients and not all medications will behave as the rules of pharmacogenetics or as data in the literature suggest, because as all of us who treat Ehlers-Danlos patients know, everyone's different. Thanks.